Okay, this is the second case from Apollo, and this will be performed by Dr. Peter Andreka. He is the director of Hungarian Institute of Cardiology, and he has trained many cardiologists from India. That's his credit. And he was the first to come to Apollo Hyderabad when in 2016 we did the first case. He was there as a proctor, and he has come many times. We are obliged to him, and he is doing this case. With him, Dr. Manoj Agrawal and Dr. Barsa Kiran are there. I think Dr. Barsa is going to introduce the case. Okay, Barsa, go ahead, please.
Good afternoon, everyone. So we have a 74-year-old gentleman who's a hypertensive and diabetic. He had undergone a bypass surgery with 3 grafts in 2016. He had a Lima to LED and an SVG to LCX and diagonal. RCA had mild disease. So he had a recent angiogram done in the month of June 22, which showed patent grafts. He's basically come to us with a history of breathlessness and presyncope since past 1 year. ECG will come up in the next slide. Basically shows a sinus rhythm with LVH and strain pattern. There are no bundle branch blocks. Echo shows a very severe aortic stenosis with a peak gradient of around 110 and a mean of 65 millimeter mercury. LV function was normal. His STS score for mortality was 5.7. So this is the ECG showing sinus rhythm with left ventricular hypertrophy and strain pattern. And this is the echo showing an aortic outflow gradient, peak of 110 and a mean of 65 millimeter mercury.
Yeah.
So the lab investigation, the one to note is he's got a moderately elevated serum creatinine of 1.7. Hemoglobin is 10.6. So next slide, please. Yeah, over to Dr. Manoj Agrawal to go through the CT analysis.
The multidimensional CT scan showed that it's a tricuspid valve with a perimeter of 63.2 and a perimeter derived diameter of 20.1. Sinuses of Valsalva were relatively okay. Since it was a bypass patient, left coronary height does not matter. Right coronary height was adequate. Left, okay, go ahead, next.
The luggage will be there in the
you can see the pictures. Annulus perimeter is 63.2.
Then you come to Apollo.
Next, it's a tricuspid valve. Hardly any calcium is there.
Cath lab state.
Next.
I have sent the case details.
These are the coronary heights. Left is 16, right is 14.3. Next. You can see reasonable amount of calcium along the course of aorta. The whole aorta is calcified. Coronaries are calcified. Next. And these are the implantation angles. Just go back, please. The coplanar view is LAO 39 and cranial 16, and cusp overlap view is LAO 10 and caudal 6. We'll try to implant this in cusp overlap view. And these are the ilia femorals. Ilia femorals are tortuous, more tortuosity on the right side. There is a reasonable amount of calcium on both the sides iliac. Left femoral is small in caliber. Most of the time it's around 4 to 5 millimeter, and right is 4.8 and 6.2 at the puncture site. So we decided to go through the right femoral and take a puncture on the left side to guide us through it. Next. So it's a tricuspid valve with moderate calcification at the arch of aorta and descending aorta, severe calcification at the abdominal aorta and common iliac artery, tortuous femoral and iliacs. So plan is to go with a Medtronic Evolute 26 millimeter. We don't plan to do any pre-dilatation, and main access, as I said, is with the right femoral. We have placed one ProGlide. If necessary, we will use one angioceal to close the hole. Next. So over to Dr. Andreka.
So hi everybody. It is my great pleasure to be here and to do this case together with the perfect Apollo team. Please, I would just want to note the poor kidney function of this patient. So we are planning to minimize the contrast load. So far, we haven't added any contrast. On the right side, we have a 14 French centron sheet. And on the left side, we have a 6 French sheet for the pigtail. As you can see, the pigtail is in the non-coronary cusp, and we have a temporary wire in the right ventricle. And we are planning to cross the aortic valve with the help of Amplatz 1 and AL1 catheter and a straight wire. The straight wire is a Teflon coated straight wire. I personally don't use the hydrophilic straight wire because of two reasons. The reason number one is that unfortunately it's very easy to perforate a hypertrophic left ventricle with a straight hypertrophic wire and with a straight hydrophilic wire, and the hydrophilic wire never gives us a good support which is needed when the valve is very calcified, and sometimes it's just really difficult to cross the valve with the AL1 catheter. So the plan is to get through the valve. Just as a secret, we have done it once, but we wanted to show you how we cross it, so we just came out. So there are actually two possibilities: to cross the valve in like 15 seconds, or to cross the valve in like 52 minutes, because it's just a matter of luck.
So Peter, that's a very good introduction.
So the patient is, yeah.
Yeah, this is Ramesh. I'm just trying to find out, with the narrow, it's only going to be 26 valve, and obviously the question is always that how did you pick balloon expandable versus self-expanding valve? I'm sure that it always comes to a discussion. So can you tell us why, in your mind, you chose the self-expanding valve?
Yeah, so it's a great question. So this annulus, as you could see, the perimeter derived annulus is like 20.6 millimeter. So it is in the range of a 26 millimeter valve, and the plan is to pick an Evolut R valve. And to be honest to you, since we are among us and we can be honest to each other, in this situation, it doesn't really matter which valve type to pick, because the balloon expandable valve works as good as this self-expandable valve in this particular patient. So we just decided to go for Evolut R because this was our first choice. So that was for no particular reason, to be honest to you, in this particular case. So we have crossed the valve. The wire is somewhere in the myocardium.
Huh?
In the myocardial cavity. Okay. So I'm sorry. I'm just trying to think. So the next step is
we saw Manoj gave
to
you a
go
look.
down with a pigtail. Yeah.
So one more question.
I got sight.
Yeah,
yes.
I know you are going to exchange for pigtail now, Manoj. I think that's a very good point for beginners as well as for
that's what we're doing now. Yeah.
Right. You have your pacemaker balloon inflated. Is that to avoid RV perforations?
Yeah,
does it make any difference?
We were waiting. We are going to deflate it before we do it.
Okay. I know some people actually keep the balloon inflated, thinking that it prevents RV perforation, but I'm not sure about that.
Since we were waiting, we thought we'll just let it go.
So the pigtail got through, and then please don't pull it out. Don't pull it out. So so it is a self-expandable valve. So it is very essential to have the pigtail right in the apex. And the pigtail and the entire system, the pigtail and after that the confida wire, shouldn't be trapped behind the cord A. So at this moment, we need to check whether the pigtail is free or not. So there's actually a very simple way. So we just need to pull the pigtail out a bit above the mitral valve and below the aortic valve. So we can do that. However, if it was very difficult to cross the valve, the pigtail can just jump it out if we do it this way, and it can be very annoying. But there's a trick, if I can show you
Yeah.
what to do. So I just go down with the wire, which goes somewhere, it doesn't matter where, and I'm just retrieving the pigtail. Would you please just hold the sheet for me? And I'm just retrieving the pigtail on the wire. See, the pigtail is coming out, and I'm going to stop right below the aortic valve, and I will play with the pigtail and the wire. So I'm just pulling the wire out, and I'm trying to keep the pigtail in this position, and I let the pigtail to form its head in this position. And it didn't jump out, so we just saved some time with that. So the pigtail is definitely free, and it went directly into the apex.
So that's a very good teaching point. Whenever
So,
you are not depending on TEE, you need to make sure that the pigtail is not caught behind any mitral valve apparatus or any.
Yes, I agree.
Okay.
It's an essential point. Yeah, can you see the monitor? So you can see the hemodynamics of this particular patient.
Yeah.
We have a very high gradient,
And what is LVD?
as you can see.
Around 20.
So the mean
And,
gradient was 65.
What is the
and
LVD?
on echo?
Yes, that is true.
Yeah. So are you going to do BAV?
It is 35.
Yes, that's another good question. We are planning not to. So it is going to be a direct implant, so that's our first idea, right? And then we'll see how the valve will behave, okay? So now the confida wire is going in. Let me just keep it here. And yeah.
So we never did BAVs initially for most of the balloon. We did BAV for every patient before, and then we shied away from doing BAVs. Now we went back to doing BAVs at our institutions. We chose we do BAV based on certain
Yeah, so what,
criteria.
yeah.
Valve area less than 0.6, AVA, AV calcium score, all bicuspids, all
Yeah.
34 valves will get a BAV. So if the valve area is 0.6 or lower, because we are shooting for higher implantations, now we don't want to run into a risk of valve embolization after doing a post-TAVR BAV. So we'd rather want to do BAV first and shoot for a higher implant rather than trying to do post-implant BAV.
Yeah, I think that's a very good point. In my institution, so let me just show you the loading of the valve first, and I'm gonna tell you our way. So this is to check the loading of the valve. As you can see, the valve is straight, so the edges are parallel to each other, and the nodes are also parallel to each other and perpendicular to the edges. And then please take a look at that big metal thing, which is like here. That big metal thing belongs to the delivery catheter. And as we rotate the valve, you can see the pedals, see, parallel to each other. And the gaps below the pedals are equal. So we have confirmed that the loading is perfect. Right? So let me just give it back to you. And would it be just? And our pre-dilating strategy. So we go for direct implant in my center in like 80% of the cases. We always pre-dilate the bicuspid valves, and we always pre-dilate the very horizontal valves. Very horizontal means that above 60. And we quite like to predilate the very calcified valves and the very little aortic valve areas. There's a mustn't. We try not to predilate those valves where there is calcium in the alveoli. Okay. Just to save the patient, because it's very difficult to tell and it's very difficult to size the pre-dilating balloon if there is calcium in the alveoli. Yeah, so I think we can proceed. I'm gonna compress the artery for you. So what we do, we have a 14 French. It's a 14 French sheet in place. It's a 14 French centron sheet in place. The outer diameter of the 14 French centron is approximately like 18 French, and then the 26 evolute R is coming. The 26 evolute R is a 14 French equivalent valve. So this is exactly the same size as a 14 French sheet. So we needed to exchange the sheet. So we pull the sheet out, and we are going in with the valve, and we are going to use the inline sheet of the valve. So the valve is in already, so there's no bleeding. That's good. And please show us the groin. Okay. So see, the valve is not moving. So there is one important thing what we can do in this situation. So please show me the wire, where the wire is. So would you please push it a bit?
Yeah.
Yes. And please go down.
We can proceed.
So what we do, we are coming back with the system. See, and we rotate the entire thing to that direction, the handle and the shaft together. And then I'm going to push the valve. And it didn't need much push. So I'm going to hand it over to you. So the reason why we did that is that there are, no, it's not going. Yes.
We can push the whole thing.
Yeah. So I think we can stop and we go up sheetless.
Yes, that's what.
Yes. So there are two spines, and the spines makes the system.
Right.
Yeah, that's good.
Right.
Stable enough. And if I want the system to be flexible to the other direction, we need to rotate the system. Would you please show us the groin? Yes, it is. Okay, as you can see, we just left the sheet where it was. The sheet is not going higher, so we went sheetless with the valve. Okay, please go down.
Right.
And then I'm pushing the valve. We have reached the arch. Would you please go to LAO?
Yeah. LAO.
LAO to the other direction. That's fine, that's fine. No, that's fine. That's fine. I can handle that. Okay, thanks, that's enough. So please secure the wire. So I'm going down with the valve. Okay, please come back to AP. Thank you. And I'm going down, and we are going to cross the valve. Yes. Yeah, would you please just push the wire? Yeah.
Push. Yeah.
Yeah. And let me just go through. Okay, it's not going. So let me just pull the system out a bit. And we're going to do the same rotation, okay? Let's do it this direction. Yes. And then push it. Okay. See? It's not going. So I think that we need to change strategy, right? And we need to pre-dilate the valve. Do you agree with us?
Yep. Yeah, we agree.
So
with
let's
that.
retrieve the entire system.
But in the
Yeah.
iliac artery
Yes,
also there is
let's-
the area you got stuck is the area where there is minimal lumen diameter is 4.9. And so whenever
Agree.
we look at CTs, we always have a backup. Axis, right femoral, bailout axis, left. If not in this patient, it will be transcarotid.
1 second, can I
Number
see
one,
can I see the heart?
then axis dilators,
show the heart.
or if not IVL. So think about all these ahead of time. Your sheet is stuck. So we use Kuhn's dilators, which are very
Absolutely.
smooth, and you can go with the nicely with the dilator. They're very not at all graded. So it's very smooth dilator. Kuhn's dilators. Have them in your lab. If that doesn't work, then IVL.
Yeah. Absolutely agree. So in our lab, we do a lot of peripheral work. Yeah. So first we try to fix the peripheral artery. So the sheet is going back in. Please show us the wire. It's still on. Yeah.
Dr. Peter,
Okay, very good. The share is in. Yes.
any plan of
I'm
changing the
listening
wire
to you.
also
Yeah.
from confida to little more
Well,
stiffer?
let us. Yeah, yeah. That's another good option. Let's pre-dilate the valve first, and then we'll see what is going to happen. Okay. It's another possibility to exchange the confida to Lambda Quest. So let's discuss the size of the pre-dilating.
So 1 minute.
It went into the mitral, I guess.
No, we'll just place it properly. Just give a picture.
Yeah, I think the picture. So please take a look at the wire. So we just lost the.
It's okay.
Yeah, I think it went back. It went back. So let's discuss the size of the pre-dilating balloon. Okay. So remember the minimal diameter of this annulus. It was 18.1, if I'm not mistaken.
19. Yeah, 19.
Yeah, it's 18.1.
Yeah, okay.
So let me ask the panel, what size of pre-dilating balloon would you pick for this particular case?
I mean, here we're just trying to get a room for the valve to go in 18. So whatever the minimal lumen for the audience, we're just saying that anything minimal lumen diameter of the LVOT or of the annulus, take the smallest one, okay? If a LVOT is 18, take 18.
The LVOT is 18.1. It was 18.1. Would you please show us the images of the annulus? Can we just...
CT scan.
Yeah, the CT scan images.
CT scan.
So we go back.
Give the balloon.
So, do we have 16 millimeter balloon?
16 is there.
Okay, good. Let's
Both.
use 16. I think that's the safest.
Wait,
Do you
wait.
agree
I
with
think
me?
it was 19 point something.
No, it was 18.1.
We
Then
have
we'll
both
take
16 and
16.
18.
It's 18.1, right?
Yes.
We'll take
The
16.
minimal diameter.
So what balloon?
So what we are discussing, so we have two balloons right next to us,
Just hold on.
still closed. We have a 16 millimeter and then 18 millimeter.
Next
So
one.
please take a look at the perimeter derived. I mean the short,
Next.
the short dimension. This is 18.1, and the LVOT is 18.4. So what do you think?
LVOT minor is 18.4 and annulus minimum is 18.1.
choice
Yes.
for this.
So
Peter,
So
suppose you
what
have
do you
taken.
think? So the suggestion was
Ramesh.
18. Yes, I heard that. 18.
suppose
Yeah,
you
you
are not
suggested
taking
us to use
Medtronic.
18. What is your?
Suppose your initial valve was Edward. Now you have landed up in these situations. Like the valve is
I would
not
go for
proper.
16.
You cannot take out
Yeah.
the Edward. Usually cannot take the Edward out. So in retrospect, the pre-dilatation was mandatory. Can I conclude like that?
I would always predilate Edwards. Always. Just like the Merrill.
So in retrospect,
Always.
you chose a Medtronic.
It's
that
the
was
other way
best.
for me. I don't always predilate Edwards. I always predilate self-expanding
It's a
valves.
kind of blessing in disguise that you have taken
Yeah.
Medtronic
So-
rather than Edward.
Right.
So
but
I personally, yeah.
But the basic problem is
So
whenever you
let
have
me
tight
just,
valves,
yeah, I'm
predilate.
gonna answer.
Sorry, Andrea.
Yeah. So it would have been a good idea to predilate this valve. We didn't do that, so we are going to do it now. But we selected the 16 millimeter balloon just to be on the safe side. So the annulus is 18.1. I personally quite like to use a balloon which is definitely smaller than the minimal diameter of the annulus. And the the smallest balloon we can get, that's the 16. That's the 16. So that's our decision to go for a 16 millimeter balloon to predilate this valve. And just back to your original comment, in our lab we always predilate the balloon expandable valves, always, and not the self-expandable ones. Well, this is our strategy.
So, I mean, as we said, like one of our balloon expandable valves as well,
Yeah.
which we did not predilate, the nose cone got stuck. And patient immediately became hypotensive and patient actually flatlined on the table. So
Yeah.
From then on, this was in
Yeah.
2015 or something, we made a rule consciously
Okay.
that every valve that is
Yeah.
tight has to
I
be
would come
pre-dilated.
out a bit
And
because
that is
it's
a
not in the middle,
checklist.
yeah.
That's what I'm-
I
We
think it's
finished the
perfect.
checklist about a
Yeah.
week prior to the tower, and we sit down and review that again on the day of the
Yes,
procedure.
please.
And all these are
Okay,
standard.
easy.
Make them
Okay.
as standard things that you say that
Ready?
I'm going to pre-dilate.
So it's 180?
Yeah, 180.
Yeah.
I think
So it's
the
180, so
discussion
go
is
for
rightly
180.
180.
that pre-dilatation, we should
Yeah.
not shy away from doing a
Okay, good.
pre-dilatation. Because and especially if you are a
Good,
beginner
very
or
good.
if,
Okay,
if you have
yeah,
not done
bottom down.
500
Facing
cases
down.
and you don't have the experience, then you can get stuck. So
Perfect, thank you.
always
I'm
it is
holding the
better
shade.
to, whether it is a self-expanding valve or it is a balloon expanding valve, you are not going to get a trophy if you are
एक mag
not
up क्या?
pre-dilating and doing it.
go mag.
So pre-dilatation always eases the task of navigating or crossing the valve, positioning it properly, and keeps your mind at peace. Otherwise, if there's a
holding the
tight
wire.
stenosis and whether it is a self-expanding or a balloon expanding, and your hemodynamic
Shall we go
collapses,
for
as you
Landa
said
Crystal?
in
We can say-
2015,
I
you
would do
had,
that, yeah.
yes, it's
I
a very
would do that.
serious
I would
complication which
say,
will
yeah.
end up, I mean, in
Yeah, let's
the
do
life
that,
of the
yeah.
patient at threat, or you will end
go
up
for an
requiring an
exchange.
ECMO or a lot of CPR would start happening.
Facing down.
And the other thing in
no,
this
we'll use
borderline situations where the rule says 1 millimeter less than the minor axis of both LVOT and the RV and the annulus you have to take, but you have to also consider calcium and whether it is, what is the type of the valve. So this is a tricuspid valve or a bicuspid
holding
valve.
it,
If it is a bicuspid valve, you have to do good dilatation. It could be the same size as the minor axis. You may not 1 millimeter or 2 millimeters less. In this case, we just need to cross the valve. So 16 is fairly good, but if we were taking 18 also, that would not have caused any injury because there is hardly any calcium, and there is, you would go at an optimum. You are not going to rupture the balloon. You just are on the fluoro, you see the waist opening and you stop there.
Groin.
That
Let's
is
show the
groin.
what I at least follow in our center.
Yeah. Good points. Excellent points.
We'll go through. Sleepless.
We can go with the
So they
the
pre-dilated
valve,
with
yeah.
the 16, and now they're going back with the sheath. Again, that
Go,
iliac
has to
area,
just
do
come
not
back
push
again.
too much.
So show us the wire plane.
We'll be regretting our decision to push too much on that area.
Yeah.
So send it
Please
sheathless.
go back to the iliac. Yeah, so I'm just stopped and let's just go the yeah, please show me the wire, please.
My approach is I go with a dilator
Yeah,
with a
good.
20 French here. I use this is only 14 French sheath. That's the 18 French outer diameter. So go with a 20 dilator. Dr.
Right, let's just rotate it to that direction.
No, I think we were having good discussion on the pre-dilate or not to pre-dilate. It's not about the self-expanding or balloon expanding. The ups and downs, the pre-dilatation, previously we were concerned
me
about
just-
causing aortic
let's
regurgitation,
just fix it because you see
hemodynamic
it's just-
compromise, suddenly rushing with the valve.
Yes,
Now
okay.
that we are not worried.
See, let's just come out
Pre-dilate,
because it's
whatever
not in
error
the
happens,
system.
you don't
Yeah.
sort of cause much harm.
Hey,
Pre-dilate in a heavily calcified,
Because it came off.
variable
Wire,
valve,
wire.
Show the
you
wire,
will
show us the wire,
pro-embolus.
please.
So the places where you
Good,
don't
very
pre-dilate
good.
is
We need
a
to take
valve
it
in
down and
valve.
take it apart
You don't
outside. See,
pre-dilate.
because there's a
A
gap.
heavily calcified valve, you
Yeah,
do
let's put it out a
pre-dilate
bit,
in a
just from the
bicuspid.
body.
But in this case, I think Peter's
Wire,
reason for not pre-dilating is
Yes,
there was
that's
not
good.
much calcium.
And we can go.
You
we can
wanted
go.
the calcium to hold the valve,
Please show us
especially
the,
self-expanding valve. You wanted to hold the
Wire.
valve. But once you crossed and
Good.
checked the hemodynamics,
Wires in
the
place.
hemodynamic gradient was
Let me
85.
just-
Your
yeah.
catheter
Let's
hemodynamic
just
gradient is
rotate the entire
85.
system. Show us
That
the
tells you
groin.
that
Show us the groin,
pre-dilatation
please.
is needed.
Yes.
That's absolutely needed.
Good. Okay.
And the second thing
Let
is
me just
obviously this
rotate it.
problem with the access. The minimum diameter was 4.8
goes. Okay.
in a calcified vessel.
Okay.
In this case, self-expanding is the
Yeah,
choice.
show me the valve.
Because balloon
please.
expanding, you need a bigger sheath,
That is
unless you are going to optimize it.
So now it's going.
It might have been a good reason, once you've seen that 4.8 calcified, to optimize. Optimized femoral is
Good.
always better than a struggling femoral.
Yes.
No, no. There
Let's
is
go.
a iliac calcium is there.
Yeah. Please show us
Another
some
thing you can
LAO,
do,
please.
IVL.
LAO 20.
You can use IVL. If once you see this of calcium, the whole chunk of
Thank you.
the
That's fine.
iliac
That's
moving
enough.
up and
That's
down,
enough. Don't worry about that. That's
use
enough.
at least 7 millimeter IVL here. So 1 to IVL will ease the problem. Peripheral IVL.
So for my brain, I always like to simplify everything. So if there is 360-degree arc of calcium at that 4.9 millimeter, I go with IVL. If there is not a 360-degree arc of calcium, I go with a
Let me just find
dilator.
out what we're doing now.
So if the dilator doesn't work, then I might
Went
still
through
go with
easily.
IVL. So that's how at least I say step one this, step two
No,
the
no,
next one.
he's going to do it.
So
He wants to
I
show
mean,
something.
what you said about predilation or not is about what are the risks of
That's
post-dilation.
fine. Everything is fine. Yeah.
So the risk of post-dilation in balloon expandable valve is not much, whereas with
Let me just
self-expanding
push
valve
it a
it's
bit.
higher. Valve
Yeah,
embolization.
that's the point.
Have
why
you had any
Bring in
valve
the white
embolizations? I definitely had valve embolization. And majority of them are happening only after I decide to post-dilate. Dr. Hazarika, are you asking any question? Okay.
I lost my chair.
So now let's get back to Dr. Peter and Andreka and Dr. Manoj Agarwal. So you cross the valve and you're repositioning your pigtail in the non-coronary.
Here, there.
Yeah.
Yes, that's what we did. So we just retrieved the pigtail down to the standing because the pigtail gets stuck between the capsule and the aortic wall, and when we start deploying the valve, the pigtail will move upwards, and we just completely lose our orientation. So next is it the cusp overlap?
Yeah.
So let's go to cusp overlap. The cusp overlap is LAO10 and caudal 6, please.
The blood pressure.
So if it happens to you that the pigtail is getting caught, remove it all the way into the descending aorta.
No. The picture is in the ANSYS. Yes,
No.
yes, that is true.
Yeah.
So we went down to the descending, and then we went back to the ANSYS.
I don't-
Yeah.
The blood pressure.
Yeah, can I just come over here and then? Yeah, okay. So this is gonna be the first time when we add some dye. So with that, we are gonna confirm both the position of the pigtail and the position of the valve, okay? So,
Injection?
yes, we can go for that.
Okay.
So, the position of the pigtail is perfect, I guess, but the position of the valve is too down, okay?
Bring it up.
So,
Yeah.
yes. So, is it all right? This is the, it is flushed, right? With,
Yeah.
Okay.
Dr. Manoj,
So, I
what
think
about
we
the
should-
hemodynamics?
We should
The
start
pressure seems to be
putting the
55.
valve down.
Yeah, we are looking at it. We are looking.
Yeah, we are
the
looking
blood
at
pressure
it.
is on the lower side.
So,
Yeah.
what we can do, I'm just coming out, okay? Just a
Yeah,
bit.
that's
Let me just come out, okay? And let's just wait until he recovers. Yeah. Let's just wait.
Give some anode.
Yeah, let's add some fluid. And can we just take a look at the pericardium?
Yeah,
So we pulled the valve back a bit because we were blocking the alveoli with the valve. We are adding some fluid.
So if you are
And
stuck,
please check the pericardium, okay, very quickly.
yeah. So
We're not stuck, so we're fine.
what Peter is trying to do in patient with hypotension,
So please check the
and your
pericardium.
valve is across, you pull back the valve, looking at other things. Two things you can do. Either if the blood pressure is like that,
Yeah.
you can quickly, it is a self-expanding valve, you don't need to probably even pace at this point of time if the blood pressure is systolic is 50. So you can just immediately go up to 80
How is
and
the pericardium? I
see,
can't see
and
it
at
from
least
here.
it opens up. You can reverse the
Can you-
hypotension.
Can you add some norepinephrine? Yeah,
he's doing
perfect,
it.
thank you.
There is nothing wrong in pulling it back and checking
There's no
to
effusion.
make sure there's no pericardial effusion.
It's okay.
Which it's
Yeah, so that's what we did actually. So the pericardium is empty, right? So the pericardium is empty. The fluid is going in, and we are adding some norepinephrine. We have some time. Let's wait. So I think it's just safer to wait until the patient's blood pressure recovers a bit. Please take a look at the diastolic
Is it the
pressure.
acute? Is it
It's
the
coming
acute
up, it's
AR
coming
that is
up.
causing the hypotension?
Yes.
I think it's the
Well,
acute
we
AR
say-
that
we're
is
saying
causing
that
the
if you can-
hypotension here. If pericardium is empty.
Yes. Yeah, the pericardium is empty, so I'm just adding some more fluid, and then okay. So I see it's. I don't. Can you see the blood pressure?
yeah, 71
The
over
blood pressure
28.
is picking up.
Yeah.
Yes.
Another reason can be vasovagal because we were trying to push it through the ilex, and ilex were very small in caliber,
Right.
and it was causing pain. So that may be responsible for it.
Yeah.
Yeah.
So.
Yeah. So a couple
so
of
the pericardium
causes,
is empty,
whenever
yeah.
hypotension, pericardial effusion because of the wire motility, Then number 2, access. Number 3, vagal.
That's
Obviously,
what I
is
said.
also you have to concern. But anything else?
In such a situation, one option could be to quickly go and deploy, it's a recapturable valve. Quickly go and deploy the valve till 80%. At least you have taken care of obstruction as well as the regurgitation partly.
So
Let the
I think
pressures recover,
blood
and then if
pressure
you
is
don't like the
better. Shall we
position,
go for it?
recapture and
Yeah.
redeploy.
Some dextrose also.
That's what Anant Raman
Yeah,
also
some
saying.
dextrose also.
Yeah,
Okay.
let's do it. Okay.
He's diabetic.
Let's do it.
Yeah.
Okay, that's good. See, let's do it. So we proceed, okay? So because the pressure is better, let's just see. So we are going in. Yes, so let's just come out. Yeah.
Okay.
We need some more dye just to check, just a couple of mLs, just to check the position of the pigtail.
Reduce
At-
the injection.
Yeah.
1 second, just hold on.
If there
10
is
ml, 10 ml.
brady
Yeah.
and hypotension, think about vasovagal. If the tachy and hypotension, it could be
Yeah, that's
pericardial
what.
tamponade.
Yeah.
So, and number 1, and number 2.
We have
if you
checked it. There's nothing in the pericardium.
Contrast tissue,
Yeah.
can you use TEE?
Enough, thanks. So I start deploying the valve, okay? So as you can see, please take a look at my hands. So I'm
I can be on the wire.
wait. Okay, so I put it on. Yeah.
Already heart rate picked up.
Please, the norepinephrine dose because the pressure went up very high. Yeah. Okay, good. Good. Okay. Okay, so let's see. So I'm just moving, okay?
Yeah.
So I've started deploying the valve. I'm holding the wire with the first 2 fingers of my left hand. Please don't. And I'm just deploying the valve. Please push it. So we are going in a bit.
Yeah.
A bit more. Yes, a bit more. Just push it. Yeah.
Yeah.
Very good. See, we push the valve a bit. I just release the wire. I'm just pushing the wire. Yeah. We are not going to add dye.
It's going, yeah.
Can you see the pressure? Yeah, okay, good.
Yeah.
Okay. So, let's check out what we have done so far, okay? So, let's go for an aortogram.
10 ml. Okay.
Okay, stop, please. That's enough. So, from this, the pressure is okay, so I have some time to talk. So, please take a look at that depth which is below the pigtail. So, it is a cusp overlap projection. So, the pigtail is sitting in the non-coronary cusp. And on the other side, in an overlap position, we have the right coronary and the left coronary cusp. And the X-ray beam is parallel to the LVOT. And that space which is below the NCC is not foreshortened. So this projection is ideal to check out the depth of the valve below the NCC. What do you think about the depth?
It's around 5 millimeter, 4 millimeter.
It's around like 4 millimeter.
4 millimeter.
So please go to a bit more LAO. Please wash your head.
So, I mean, I think the position is not bad. It's a little bit deeper than where we normally would like to, but in this patient it's okay.
Yeah, but
And
yeah.
one question is,
Yeah. So
where
let's
is
check
the
out-
A line?
Yeah.
So in a patient with self-expanding valves, what we have seen in porcelain aorta or aortic arch calcifications, one of the other reasons we didn't talk about hypotension is aortic dissection. So if the A line is in there, so it happened to me,
Yeah,
and that's fine.
so,
It's all my self-experiences.
Yeah, but
which
there
are
was nothing-
not good to tell, but
Yeah.
radial A line is on the left side for us
Yeah.
all the time. So the radial A line blood pressure was very low.
Yeah.
Then we thought, okay, it's not, we connected it to the femoral. Femoral was slightly higher, so then we thought, okay, so it's all right.
please,
But there was a
okay,
dissection in the
Please come a
arch
bit more
extending
closer.
into the
Let's
left
just check
subclavian.
out the parallax. Okay, is it better,
Yeah,
right?
it's okay, I
Okay,
think, yeah.
so let's go for an aortogram, please.
Okay, looks very good.
So what do you think?
On the left side, you look
So we
great.
are checking
it's
the
less than-
valve. It's around like 1.
Yeah, it's like less than 2 millimeters depth
Am
on
I-
the left side. So, you know, it's a very good implant. You did not use pacing at all. Did it move up is my question.
No, it didn't. No, it's just a virtual thing. So what we can see now, so we just changed the projection. So we went a bit more LAO just to check out the the valve below the left coronary cusp.
Can you go back to the cusp overlap one time?
Yeah. Yes, we are doing it.
that's
We are
what we
doing it.
precisely
That's what
did.
we are doing.
I know we are
It was
running short
LAO
of time, but
That's the one.
we'll keep.
Yeah. So we are.
Okay, you want?
That looks good, actually. Yeah.
Yes. So what about putting it down? Do you agree?
I agree.
So let me pull the wire. So I've pulled the wire, and please push the valve a bit, and I'm very, very slowly opening it. See the way how I'm holding my hands? This is very convenient for me because I can safely and securely control the wire, both the wire and the handle. Push it a bit, push it a bit, please.
Yeah.
And please note that the pigtail is in a trapped position. It's in a gelled position. Okay, very good. Okay, so let's check whether the valve is free or not.
It's not.
Pardon me?
It's not free.
I don't, that's not, let's check it. So please push the entire system in, just to see what is happening.
Yeah. The one
Yes.
is- yes.
Okay, so just please push it in. Let me just pull the wire a bit. And then you can, let me just push it a bit.
Rotate.
You know, well, let's just push just to see.
Yeah, that's
Yeah,
okay now.
no, it's good now. We can
Looks
roll
good.
it a bit, and then we can just,
Okay.
that's very good.
That's
Let
good.
me just push the wire a bit. And okay, I will just, good. Okay. So, I don't know whether you saw it or whether you realized what we were doing. The valve just got stuck on the delivery system, so we needed to open it fully, and we just pushed it a bit further down towards the LV, and then that's how we made it free. And then we centralized the nose cone, and now the valve is in place. And so I'm just closing the delivery system.
Yes. So yes.
Okay, the delivery system is closed. We're gonna need a sheet, and please go for an exchange. I'm gonna push the artery. Yeah.
Peter, that was a very wonderful demonstration of the how you can release a valve, a pedal holder which is kind of stuck on the valve. And this often happens in such an anatomy where the ascending aorta is very short and the angle between the ascending aorta and the valve delivery pedal holder is so acute that it just doesn't release sometimes.
Yes, you are absolutely right.
Yeah,
So that is basically the technique we should do. So I was playing with the wire, and I just changed the orientation of the delivery system, and I just pushed the system a bit deeper into the LV, and I was pulling and pushing the wire very, very gently. And then we could make it free.
And the patient height is only 5 feet.
Yeah. Oh, yeah. That's another, yeah.
Yeah.
They cannot see him, but that's...
No.
yeah, it's
that
important.
may be responsible
yeah.
for the whole thing.
Yeah. Definitely.
Ratha Babu. Sir, हैं पीछे? Sir, do you want to dilate?
I don't want to dilate it because I mean, it's just... Okay, good. So let's just put the pigtail down. Yeah?
Pigtail.
So the pigtail is going down. So please take a look at the diastolic pressure. The diastolic pressure is looking pretty good. So I'm hoping that we are not going to have much paravalvular leak. And the other pigtail is still in a jailed position. So we need to make it free. So the pigtail is going into the LV. Yes, it's in already. Yes. And please give me regular J wire, just to. So what I'm doing, I'm just pulling the other pigtail out of the gel position with a wire. So I'm just going in with a wire. As you can see, I'm just pushing the wire in.
Yeah, center. Yeah, wonderful.
Yeah, no, I'm just.
Nicely jade.
The valve looks constrained at the LVOT, right? So
Yes.
now the
agree.
question to you is,
Yeah,
would you
we'll
post
see.
dilate or
Can I
not?
get another wire, please? Because it's just, yeah, yeah. We're gonna find out. There is some visual gradient, but the pigtail is
It is
still trapped.
enfolded.
So
And look at the diastolic
Anand
AR
Raman,
index. Look
what
at the AR index, the hemodynamics
Yeah.
back, and look at that pigtail and that side of the valve. It is enfolded. Unless you push it with the balloon, it's not going to settle down. And look at the AR index.
Ramesh, I have a question. Like this 1 millimeter, 2 millimeter, or 0 millimeter position, what we try. Do you really think
which
these are
one
the
is
ideal
that? This is
positions?
not the
Because
active, right?
if at all, if you require a post dilatation, it will be a good amount of chance for that valve to pop out, and we'll really have a restricted hands to do a post dilatation in that kind of scenario. So is it better to have 2 or 3 millimeter position, because you don't know whether you will require a post dilatation? Now in this case, it looks there is an infolding on the NC side, and that will be taken care of only by the post dilatation, if at all. And there will be a
Can I get that
good
thermal wire,
risk
please? The
to
thermal is down, right?
pop out the valve.
So for the audience, what Anmol is saying is, be careful. You only have 1 to 2 millimeters depth. If you're post-dilating, you have to be a master in post-dilating self-expanding valves to make sure that somebody who's on the pacemaker is really listening to your commands, and don't absolutely stop post-dilation, don't pacing while the balloon is inflated, and do not actually stop pacing until actually the balloon is back into the arch. So that's how much you need to be very careful in this one. So, my approach would be, I do aggressive. I'm not conservative at all, because Tower is not conservative approaches. I do aggressive pre-dilations, meaning if it is 18, I go to 18 or even 20.
Okay, thanks. I didn't have enough hands.
MLDs, average diameters, and then so that I can avoid post-dilations. But if you have to post-dilate, you have to take the risk. You need to do it very carefully.
Yeah, so let us see.
So the gradients here
what
look
we
better
have.
now
So,
after re-zeroing. I think it is better, right?
Yes.
There's no gradient.
Okay, so let's go. Yeah, let's go for an aortogram. So we are going back in with the pigtail.
See the height.
Yeah. That is, I
There
think,
is hardly any ascending
pretty
aorta.
good. Yeah, that is
There is
true.
hardly any
So
ascending.
did you see that we don't have much ascending aorta. So the length of the ascending aorta is very short.
Caudal? No, go to cranial. More cranial. More cranial. More cranial. Some more. And little bit LAO. More. That should be okay.
So
Okay, more.
I think it's pretty good. So let's go
This
for
looks
it.
good.
Yeah.
Go to
Looking
cranial.
Very good. Yeah. So we are going for an aortogram. Let's see. And then we're going to check the valve with echo as well. Okay?
And eternal will take some time to expand as well.
Do you think a small balloon expandable valve would have been better? Even the short length of the LVOT, sir?
Yeah. So, see, there is no gradient and there is no paravalvular leak, right?
Come to the RU.
So, what we will do?
I think you're done. I would not actually, I would accept whatever it is.
I also think we are done. Yeah, yeah. I also think we are done. Just in case, we're gonna check the valve on echo.
Ramesh, I know I want to
Yeah, let's go for it.
re-emphasize the role of IVL here. The amount of force he was applying on the
Yeah.
valve system was actually dissipated on the iliacs. Most of the energy was in the iliacs, not actually in the valve. We are thinking about the valve, tight valve, and that's why he was really holding so tightly the wire and the valve system. The pressure is actually was on the iliac, 4.8 I think was Anand was mentioning. So had it been IVL in the iliac, it would have been much easier. The force you apply you actually will be transmitted at the aortic cannulus level or the valve level rather than iliacs.
Yeah, so the pressure, what we used in the iliac, it was not much, to be honest to you. So instead of pushing the valve very hardly, we were rotating.
Brother, can you show the echo?
Yeah, we were rotating the system just to let it be flexible to that direction where it was needed. And then we just stopped with the sheet and we went up sheetless. So I think it's very essential not to put a lot of pressure. Yeah, so not to put a lot of pressure on the
Take
delivery
a short
system.
axis and a parasternal long axis.
Yeah. So we are checking the echo. Is it visible?
Yeah, we can see it
good,
now.
Very good.
We can see the
Good.
echo.
So you can see the echo. That's very good.
Right. LV function is
okay.
normal,
So please
and there's no
concentrate on
pericardial
the,
effusion.
yeah. I think you could, yeah. That is true. So normal LV function, no pericardial effusion. You check the gradient, right? And it was basically nothing.
You can see that.
Oh, yeah. Okay. Sorry, I didn't see that. And let's check out the paravalvular leak.
Short axis.
I think somehow we had a disconnection. So anyhow, I think based on the gradients, there's no AS, and based on the diastolic blood pressure, there may be some AI. If with self-expanding valves, we accept mild to moderate AI immediately, and it'll get better tomorrow. It'll be mild to trace. So we'll take it that way. Thank you very much. And
Oh, you can. Okay, very good. So did you see the paravalvular leak? Yeah.
The valve is expanded.
Yeah, the valve is, it's expanded. So I don't know whether you saw it, but there's a very, very tiny, it's like a trace paravalvular leak, and the gradient is basically around like 3 millimeter mercury. So I think that this is the right time to stop.
So Peter, we are more interested in the iliac artery according to the panelists here. So could you just quickly close the right femoral and take an angio?
Yes. Yes, definitely.
Yeah.
Definitely. So we do that very quickly.
Yeah, Dr. Sitaram gave us 1 minute.
So we are coming out of the LV.
And can you ask them to go back from echo to angio and your faces, please? Thank you. Yeah, we can see you now.
Good. Okay, no problem. So you can see us now? That's good. Can we get the dilator of the sheet, please? The 14 French dilator, please.
We'll take another.
Good. Okay, very good.
Take a niche. Just show us down. Sister, can you give me another wire with the dilator? Just give another wire, not that wire.
Okay. Okay, so we're going in with the dilator. And you're gonna, I'm holding the sheet for you. Good. I'm gonna compress the artery. Can we get the knot pusher, please? Yes?
Not pushing.
So we have only one ProGlide in place. Okay, thank you. Just please put it down. That's fine. That's fine. Okay, please do it because it's just easier for you. I'm going to compress the artery for you.
Take it. Yeah.
Okay, good. The sheet is coming out. Okay. Perfect. Good. I'm not compressing it and there's no bleeding, so I think it's just...
If they want, they can see iliac from the other side.
No, that's a big tail. We can put
Yeah.
I
Take
can
it.
put a JR.
Good.
Yeah.
I can take a JR.
Yeah, JR, take it.
Give me a wire.
Let's just go for a selective one. So
Yeah,
with
that's fine. We'll
like
take
a
it.
JR1
Yeah,
or a Lima or whatever.
And
We're just discussing here amongst us that so anyone with less than 18 French, you can try with 1 per close and plus an angioseal or a minx or whatever you want. More than 18, at least our institution, we use 2 per closes.
So here, yeah, absolutely agree. So here, we decided to position only 1 ProGlide, and then we will see whether an angioseal is needed after that or not.
Right.
At home, what do we do? So we also use 1 ProGlide, and when we pull the sheet out, I put an 8 French sheet in, and I tighten the ProGlide around the 8 French sheet. So basically what I do, I make an 8 French hole. And then I close that controlled 8 French hole with an 8 French angioceal. There's no bleeding.
Hardly.
There's no bleeding. So would you please concentrate on the groin with the camera? So let's just ask for the opinion of the panel. So please just, the bleeding. I don't think it's going to be visible because you need to show it from that direction.
Get me thermo.
Yeah, we can see the, I mean, your
Or
per
with
close,
another one, okay.
per close
So
is
can you
equal
see the
to-
bleed? Yeah. So, yeah, I don't think you can see it. So, but
Yeah.
anyway, so let's just take a look at the bleeding. Oh, yeah, you can
Yeah,
see
we
it
can
now.
see that,
Oh,
yeah.
very good, very good. So, let's decide, okay? So, let's pull out the knot pusher.
Give me some contrast.
So that is the bleeding we get. Shall we put an angioseal in? What do you think?
Usually,
Yes, it's not. It's just oozing.
yeah, usually that will go with manual pressure. So I think you can leave it.
We can
Yes,
we can
fully
check
agree.
we can check the
Fully
angiogram
agree.
from
So
the
see
other
what
side.
happens. This is my.
We can check with an
So
angiogram.
that's my
yeah.
hand here. So
Wow, there
agree,
is something
agree.
there.
So I'm compressing the artery, and there is no bleeding at all.
And he has a femoral AV fistula from his previous procedures in the past.
Oh, that's good. I didn't know that.
Yeah.
That's good. So
Thank you for letting us know. Everyone was concerned about that.
That's why there is no oozing outside.
Yeah, that's true. But you were concerned about the iliac right below the bifurcation, right? So please
we'll
show
do
us
that.
the iliac right below the
Yeah.
bifurcation.
Above, go above.
Yes.
Yeah,
Am I
take-
right? Because that was
that's
a
what-
tricky point as well.
Right, yeah, right
Yeah, let's just take a
internal
look.
iliac.
Yeah, you're absolutely right.
Okay.
Yes. So,
It's just a tortuosity with
yes, that is tortuous, and the dye goes into the external one. So, but I think it's really good. Do you agree with me that I'm not worried? Okay.
It looks
so
very good.
Anyway, thank you very much for the entire team, and for the panel and the audience.
Take it out.
Thank you so much,
Yes,
sir.
I would do that.
I thank all the chairpersons
Thank
for
you,
patiently
thanks.
chairing the session.